Well, hi, everybody. Welcome back to our. We try to do this every quarter, so I think we're on the flow. This is a partnership between Acute on Chronic and GWCIM Center for Integrative Medicine, and we're gonna be talking about CBDV today. As usual, our team is Rebecca from Acute on Chronic, Abe, and myself from GWCIM. And with that, let's jump right in. But before I do that, just real quick, before we're going to actually talk about CBD, we're going to give you a little bit of our personal updates. My personal quick update is that my softcover book is out, Medical Marijuana, and the hardcover came out in fall 21. This is a softcover. It's slightly updated, and it has a little bit on CBDV in there, just a little bit. I think that's going to be the theme of today, just a little bit. So that's my update, and in no particular order. What about you guys, Abe, Rebecca? What's new with you?
Yeah. So if you want to hear more of things like this, so I was actually recently on a great podcast with Dr. Andrew Weil, who is a big deal in integrative medicine. It was like a huge honor. It feels like really official and mainstream. So I put it in the chat box. So check it out. And then Acute on Chronic is nationwide. We're excited. We are now getting international contracts to teach doctors in Europe and Canada. So that's exciting. We have a new subscription model and service. So check out our website, www.acuteonchronic.com. And we're always looking for more partners. But yeah, check out the podcast and more like this. And we're going to share these on our YouTube channel as well.
Great. And Abe, you want to tell us what's up with you? Outside of the fact that you just told us that you're in the best possible setting with 7 mango trees collecting mangoes every day.
Yes, I'm coming to you live from rural Costa Rica in Guanacaste, the Pacific Northwest. I live in a town that is pretty small that my great-grandmother actually founded. My parents live in the same town about 5 minutes from me. So I'm here working remotely. I work with cannabis and CBD websites all over the world. In the US, the UK, Canada, and so I recently just started working with another partner called CBD Oracle in California. But my main clients are Verihil. Cannakeys. Verihil is the largest prescriber of medical cannabis cards in the US. I'm their lead medical reviewer, and so I head up all of their medical editing.
Wonderful. So with that, let's jump right in. First, we're going to give you guys a little bit of a presentation on CBDV, and then we're going to open up and just start telling you our personal experiences as well as how we use it. And then at some point, we'll switch to questions. But I do suggest that if you have burning question, don't hesitate putting it in a chat, and we'll try to integrate those questions as they come in. Abe, I think you're up.
Yeah. Are you going to pull the slides up, or?
Do you want to drive them? I think it's probably better if you do. You're a co-host, so you should be able to just share the screen.
Okay, let's see. That would be screen. Okay, I just got 4 computer monitors, and so I'm seeing 8 different possible ways to outline this. Screen.
You want
2.
me to do it? I can do it. No, okay, so you got it. There we go. Very good.
Okay. Yes. Okay, great. So, all right. So today we're talking about CBDV. And so, like I just introduced myself, I'm Dr. Benavides. I do canna coaching with GWCIM and Verihil. These are all of my industry partners and my affiliates that are laid out here. Okay. So what is CBDV? CBDV stands for Cannabidivarin. It is one of the minor cannabinoids. And when I say minor, I don't really mean minor in terms of effects. We really mean minor in terms of quantity. So they are quite rare to find, but in generally it is well tolerated, and it is also non-euphoric or non-intoxicating, if you prefer to think of it. I don't like to think of things as non-psychoactive because that implies it has no effect on your brain or your thinking, but it does, just in a more subtle, non-euphoric kind of way. CBDV is mostly found in CBD dominant low THC strains. So for you nerds out there, that would be a type 3 chemovar, or type 3 chemotype. And so what that means is the best example of type 3 cannabis is hemp, right? That's where you have really, really high CBD and other minor cannabinoids and low THC. CBDV was first isolated in 1969, and prior to that, we used to think that all cannabinoids had this 5-carbon chain that you see on traditional cannabidiol here. And so CBDV actually kind of changed the way that people look at and classify cannabinoids. And so if you look at the molecular structure here for cannabidiol that we're familiar with, we see in the orange circle that there are 2 extra carbons here. And so those 2 are not present on cannabidivarin. Okay, so the only real difference between varin cannabinoids and you know, the other ones that we are more familiar with is just the absence of these 2 carbons. Okay, and so there are several types of these varin cannabinoids. We have cannabichromavarin, cannabidivarin that we're talking about today. We have cannabigeravirin, and we have tetrahydrocannabivarin as well. And these all have very unique and interesting properties because they're missing these 2 fewer carbon atoms. If you have at all studied organic chemistry, you would know that even just one atom or one atom in a different place makes a whole world of a difference. Okay. So now let's talk about what receptors research is telling us that CBDV is acting on. So in terms of the endocannabinoid receptors, classic CB1 and CB2, there's actually very little binding affinity there from CBDV. It's thought that it binds much better to CB2 greater than CB1, which would explain the lack of intoxicating effects. So just to quickly review, CB2 is predominantly found in outside in the peripheral body outside of the brain and spinal cord. It's more of an anti-inflammatory signal. And CB1 is predominantly found on neurons and in the central nervous system, where we process pain, but also where we process psychoactivity from that too. In very, very high concentrations, it's possible that you could activate CB1, but in practice, this has yet to be seen really. So I'm not really sure what dose it would take of CBDV to actually feel any psychoactivity from it. That hasn't been documented yet. So basically, these 2 receptors activities are involved in, CB1 and CB2 are involved in inflammation as well as pain, nausea, seizures, and neuroprotection too, among other activities. Okay, the other channels that it works on are called TRP channels, or transient receptor potential. These are ion-gated channels. So in terms of activation, you can see that it's working on the vanilloid type V1 through V4. It's also working on the ankyrin type 1, TRPA1, and inhibiting TRPM8. So what does this mean? Basically, these channels are involved in modulating or reducing chronic inflammatory and neuropathic pain. Also, the TRPA1 is good for, the TRPV1 is good for reducing intestinal inflammation. And they're also involved in nausea and seizures and itching. Next are the G protein coupled receptors, or GPRs. Here we have GPR55 and GPR6. GPR6 is more involved in an anti-proliferative or anti-cancer mechanism. It helps to arrest cell cycles that are going bad. And the GPR55 is also really well known in helping to mitigate chronic inflammatory and neuropathic pain. Okay, an interesting target is dopamine receptors as well. So it's a partial agonist at D2, dopamine 2 receptor, which is similar to how we know that some antipsychotic medicines work. For example, aripiprazole is a partial D2 agonist. And so this opens up the possibility of it having a role in learning, as well as memory, emotion, cognition, and movement. And so we know that dopamine levels are really altered in a lot of these conditions, a lot of the ones listed here. So Alzheimer's, Parkinson's, neuropathic pain, epilepsy, anxiety, schizophrenia, and also influences our mood as well. And so having some activity at the dopamine receptor could possibly, have a lot of therapeutic benefit in there. Okay, and then we're also having CBDV work on GABA receptors. And so GABA receptors are really well known for being targeted to reduce seizures and also anxiety. But even still, whereas we know it does work on GABA receptors to some degree, we don't really understand the anti-seizure or anti-convulsant mechanism of CBDV. That hasn't yet been fully fleshed out. Okay, so now we're going to talk about how it interacts with the rest of the endocannabinoid system and also some of our enzymes. So some of you may know that the endocannabinoid system is a combination of the CB receptors, the endocannabinoids, and the enzymes that make and break down these endocannabinoids as well. So DAG-L, or DAG lipase alpha, is a enzyme that's responsible for making 2-AG, which is one of our two core endocannabinoids. So what it means is it's a weak inhibitor of DAG lipase, but at the same time, it also inhibits or stops the breakdown of the endocannabinoid. And so the results of this it has really unclear implications, because at the same time, you're stopping production of 2-AG, but you're also stopping the breakdown of 2-AG. And so what this really means at this point, we don't know. We know so far that 2-AG is fluctuates with our sleep-wake cycles. It's really diurnal in its patterns. It does play key roles in overall brain health, so neuronal, psychological health, and also our processing of pain. We also have plentiful stores of 2-AG. Normally, we actually have in the brain, there's 170 times the concentration of 2-AG, more than anandamide. So there's a big pool of it already. And so starting and stopping production of this big pool, we still don't know what that really means for us. So what we also know about it is that it does stop the breakdown of anandamide. And so by stopping the reuptake and inactivation, we are indirectly boosting anandamide signaling. And so that is overall increasing our endocannabinoid tone. Okay, and anandamide, just to review, is really important for regulating our brain activity. It's also the molecule that's responsible for the runner's high, or the feeling of pleasure after an intense exercise or an intense running. And so people used to think that that was due to endogenous opioid production, but my studies have shown that if you knock out anandamide, you no longer have this repair and good feeling after exercise. Anandamide is also interestingly implicated in our reward circuitry, which opens it up to being a target for dealing with addiction. And so, hopefully by modulating that pathway, we can change the feelings of pleasure and reward after using, other recreational drugs. So what we've found in general when we measure anandamide levels in patients is that we find that they're really altered in things like autism spectrum disorder, fibromyalgia, complex regional pain disorders, PTSD, psychosis, and schizophrenia. And so sometimes they may be too low, or sometimes they may be really, really high levels of each. And so it's telling us basically that there may be some interaction of the endocannabinoid system in these diseases where Western medicine hasn't really figured out a true underlying basis yet. And so that leads into also clinical endocannabinoid deficiency theory, where some people just make less or different levels of endocannabinoids, and that affects our overall well-being. Okay, in terms of prescribing, so CBDV is an inhibitor of CYP450 and CYP1A1. These are enzymes that are important for breaking down medicines. I think the CYP450 is responsible for breaking down somewhere around 90% of all prescribed medications, and so it's not necessarily something to be overlooked. CYP450, excuse me, is like a super family involving other receptors involving other enzymes that break down important medicines like blood thinners like warfarin, antidepressants, statins, anti-epileptic medications, and many more. This inhibition may be less than CBD though. CBD is shown to be an even more potent inhibitor of CYP450 and 1A1. And so whether these CBDV effects on raising the medication levels of other medications are likely not to be clinically significant. So even if CBDV does raise your level of one type of medicine, does that actually make a difference or introduce any toxicity? Most likely not. Okay, but it's something that you have to be careful with, in particular with these types of medications that are listed here.
Yeah, I can add one little piece to that. So the importance there is we think that if you take the CBD, CBDV, and all these molecules under the tongue, and very little gets swallowed, that impact on liver is very minimal because of the so-called lack of first pass. When the drugs or the CBD or CBDV in this case pass through the liver on that first pass, that's where most of the interaction is going to occur. So you're going to hear us continuously pounding on the same point that we like to give things under the tongue. That is why, because that almost completely, I wouldn't say completely, but almost completely nullifies this possibility of interaction.
Excellent points. Yes, thank you so much for making everyone aware of that, Michelle. Okay, so let's talk about what the potential clinical significance is of CBDV. So far, the biggest impact that's received an actual approval by a medicine agency is by the European Medicines Agency, where CBDV was approved for Rett syndrome and Fragile X syndrome because of its anti-seizure activity. So in 2017 and 2018, they were granted, and that was an effort pushed by GW Pharmaceuticals. We have no relation to GW Pharmaceuticals, but they basically are the same makers of Epidiolex, if you've heard. And so that's pharmaceutical CBD that is available in the US, but it's only CBDV. So it's only CBD. So they're now trying to prove the same thing with CBDV. And so the preclinical studies were promising in showing anticonvulsant properties. And so CBDV had a greater anticonvulsant effect when it was combined with CBD, the original anticonvulsant that received approval. And so it went on to phase 2 randomized clinical trials, but unfortunately it did reduce seizures by 40% in the treatment group, but it also reduced, the placebo group also saw a 40% reduction in seizures as well. And so while there was a reduction overall, it didn't outperform placebo group, which technically counts as a fail. And so they're really wondering why the placebo group had such a different effect than in the past. So they need to go back and rethink the approach there. Some of the things that they could redo are trying with a higher dose of CBDV. Also, the CBDV that they used in these phase 2 trials were actually purified CBDV, and so it was not a full spectrum extract, as we know are generally much more effective than isolates. So I like to say that cannabinoids work like a symphony, and so they're really best when you have all the instruments playing at the same time. So if you've only got one instrument, it's likely not to be as impactful as if you have the entire symphony. And so that's why we are always recommending FICO to our patients, or full extract cannabis oil, because it's just does have a greater effect, and that's a phenomenon called the entourage effect, where it works together also with the terpenes in synergy. They can also think about using younger patients in their studies, just like they did with the Epidiolex studies, and then try to use a longer duration. I think that the phase 2 was only like 2 weeks in duration, so they should see if there's more effect for longer. Okay, next is autism spectrum disorder. So 15 to 20% of ASD is actually associated with genetic conditions. So these are conditions like Fragile X syndrome, Rett Engelmann syndrome, but also tuberous sclerosis and neurofibromatosis. And so we know that in ASD, some of the contributing pathology to it, or some of the contributing factors, include dysfunctions in the immune system, also a lot of inflammation. Other things that cause ASD are fetal exposure to anti-epileptic drugs as well. And so what we observed in children with ASD is that they have lower levels of endocannabinoids like anandamide. Okay, and so they thought, the current thinking is that if you give external phytocannabinoids to help restore the balance, then you may see improvements. And so what they did was gave CBDV to mice, and they found that in mice that had induced ASD from anti-epileptic drugs. And so they found that the CBDV was able to actually restore a lot of the endocannabinoid signaling in the brains of these mice. And it did that by normalizing the levels of endocannabinoid enzymes, such as FAAH, MAGL, and also the CB1 receptor 2. And then in addition, it was able to reduce neuroinflammation overall. And this actually led to observable improvements in a lot of social and developmental areas. So they had improvements in memory, in cognition, in social interactivity, also in their locomotion or motor coordination, and also in the brain weight was also better normalized. To date, there aren't any approved core symptoms or drugs that target these core symptoms. And so finding something that will be helpful to relieve these core symptoms of ASD is of utmost importance. They tried giving 600 milligrams of CBDV to adults, and then they measured certain pathways in the brain, and they found that it modulated glutamatergic and GABAergic pathways, which gives further evidence to the implications of those pathways. And so CBDV and CBD have been moved on to phase 2 RCTs, or randomized clinical trials, that are currently now recruiting. Okay, other conditions that may be useful for include nausea. Preclinical studies show it alleviated the nausea in mice, and this was due to a similar mechanism like THC that we classically know, but without the intoxication. So that presents a clinical advantage there. Okay. And for Duchenne muscular dystrophy, so they gave CBDV to mice with DMD, and it actually improved the quality of their muscle and their movement. It slowed muscle degeneration and also showed really good anti-inflammatory and pro-autophagic effects. So meaning that it was able to break down other cells, sick cells better. But we don't have any clinical data behind this yet in humans. In terms of ulcerative colitis and inflammation, this seems to be pretty promising. So we know that in the past, a lot of ulcerative colitis patients have reported using medical cannabis with really good symptomatic relief. And so this has been documented in many surveys. CBDV is able to activate and desensitize TRPA1, which really plays a pivotal role in reducing intestinal inflammation. And the other thing that they found is that it changed the dysregulation of the microbiota in the gut. And so it was able to help, push it back to a more normal or a healthier, rather, balance of gut bacteria. And when they took colonic biopsies of pediatric patients with ulcerative colitis, they found that there was less inflammatory cytokine expression. In terms of chronic neuropathic pain, and neuropathic pain derived specifically from advanced HIV infection, CBDV was safe, but there wasn't any real significant difference shown or any improvements in quality of life using CBDV in patients with HIV. They thought that this may be due to there being too little CB receptor activation, despite that they used a 400 milligram dose. And then these are conditions where we don't have any preclinical or clinical studies specifically involving CBDV. So those are things like Alzheimer's and Parkinson's disease, multiple sclerosis, and cancer. But our colleagues here will tell us shortly about their experience with using CBDV in these kinds of patients. And
Great.
so these are all my
Thank you.
references. And if you guys know me, I'm a pug dad, so I used DALL-E 2 to help generate these really fun AI images. So if you don't like seeing a wall of text, you can look at the great images. So and you can refer to these whenever you'd like.
Thank you, Abe, so much. So I have two little things to add. I'm about to share my screen, and then right after that, we're gonna first go to Rebecca to tell us a little bit about what she does. And then I think after that, it sounds like the first thing we're going to do is talk about sourcing and dosing, because it sounds like those are the questions. So one thing I want to mention is CBDV sparked my interest probably about 2 years ago. And this had to do with the fact that there's been an article that I'm about to show you. So this should be on a screen now. That looked at the multiple different cannabinoids for Alzheimer's disease. This is a model that is a standard model of use, looking at how does the certain chemicals can protect us against Alzheimer's. And so what you're seeing on this slide is this table of what's called oxytocin, which is basically a brain cell induced death, energy loss. This is the plaque toxicity, and then trophic withdrawal and inflammation. So those are all factors that are critical in an Alzheimer's pathway, in a pathology of Alzheimer's. Probably oxytocin and inflammation are most important, although arguably all of them important. And so a lot of compounds have been looked upon. And one of the few things that CBDV seems to be the best at, as you can see, this is the line. Inflammation, all cannabinoids do roughly suppress on neurological level about the same. So, whether you use CBD or whatnot, believe it or not, but the delta-9, delta-8 THCs are most important ones, but you really can't take them in the massive amounts, right? Because if you compare the dosing here, let's say if I give somebody 500 milligrams of CBDV a day, if I give somebody 500 milligrams of delta-9, they're not going to feel well. No matter how adapted they are, although I guess some people can take that much, but most people cannot. And so, of course, CBD has been the most studied, but CBDV and some others like CBG, for example, are all up there. So this is where my interest to this molecules came to be. And I think one of the interesting components is what Abe mentioned about neuroexcitation. It seems to be a pretty good blocker of neuroexcitation similar to CBD. So that's all I have to add, except for one other thing. I have one case now of a patient based on the recent study that was published, which I'm going to try to find a link as we talk, of combining CBDV with opioids and seemingly have a pretty strong sparing effect, potentially just as good as a sparing effect with THC. And so this patient was rapidly dropping opioid doses, but not completely. So it decreased the dose and did really well with neuropathic pain. Of course, there are other tools for that. So with that, I'll pass on to Rebecca to share her wisdom with us, and then we'll go right into questions after.
Yeah. So one thing when I was thinking about CBDV and if we had used it, so in most markets, it is hard to find CBDV available. It's typically not extracted and nobody's really looked at it. Abe did a great job of really all the information that's out there on CBDV, you just got it. As much as the science knows. But I noticed one of my favorite vaporizers that I recommend as a starter vaporizer to people does have CBDV in it. And actually, some of our best work where we have seen people go from lots of clinical symptoms like restless leg syndrome, agitation, sleep disorder, and pain, use this vaporizer that has a combination of CBDV, CBG, CBD, and THC. And that's pretty interesting. And so like, I am not sponsored by this brand at all. I just recommend them a lot. I actually have a picture of it. If they would like to donate to research, we of course encourage that. I will show you the product. It's only available in 3 states, but so do we know if CBDV is the factor here? Not officially, but it's certainly interesting that this is the vaporizer that has really helped our patients. So this has been the one. I always use it as a starter vaporizer because it has some terpenes, it's CO2 extracted. It's one of the few products that I've ever seen with CBDV in it. So that's something that has been successful for our patients.
Rebecca, do you know if this one is available in more than just Illinois? I mean, what states is it in?
Illinois, I just saw it. Illinois, Massachusetts, and Nevada. Those are the 3 states.
Mm-hmm.
Yeah. So that's where we've seen some really incredible things. Is it the CBDV? Is it the CBG? I always get very heavy-handed with CBG. But like Abe said, it really, 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 cannabis is a symphony. And, you do need multiple instruments to make a good sound. That doesn't mean that you can't have a good song with just a trumpet. It just means that your music's going to sound better with a trumpet, a violin, and a piano.
Great. And so the sources so what other sources are you using before I put what Abe and I are using for the CBDV? Do you use any other oral CBDV products?
So we've been considering using an oil that is based off of like through a hemp market, but we haven't yet. It's kind of that overlooked cannabinoid. We've only used it in combination of like FICO oils. So that's the full extract spectrum oil, and then within this vaporizer. And then just to note, what is it that we do, my team does. So we are nurses and doctors that utilize a nursing methodology to get patients safe and effective cannabis care. So when you think of, am I going to take cannabis to feel better? It's never a one-time thing. It's kind of like therapy, where you could go to therapy once, but it's not going to fix all of your problems. It might help, but one appointment's not going to do good. Where people see us over a length of time. So a lot of our data comes from seeing people over a long progression, and our nurses go up, go down on different cannabinoids. And sometimes we find one cannabinoid that works, which is pretty rare, but sometimes it does. Oftentimes we see the symphony effect. So that's how we've used CBDV in the past, always with other cannabinoids. But would I use it if it were more highly available? Yes. And I just learned today about this other company that has CBDV. So we're definitely going to try it.
Yep. So this is the company we've been using, and stay tuned as I put in the chat. If you would like to try to win the raffle, this is an actual bottle that we will be mailing to whoever gonna end up winning. Oh, sorry, I gotta turn off my blur, but okay. So yeah, this is the products that currently comes in 750, 1500, and 3000. I'm primarily using 1500 and 3000. And the way I've been recommending it so far, it's kind of similar to the CBD dosing, maybe slightly less, but I think you do have to get up the dose to probably at least 50 milligrams a day, and probably more, probably closer to 100 milligrams a day. Do notice that when Abe was doing the presentation, that they were using doses as much as 600 milligrams a day in some of the seizure studies. But again, this is just the trumpet. Remember, there was no concert in here. It was just the symphony. It was just one instrument. These are full spectrum products. Moreover, just like I think with most of the Miriam hemp Oh, you cannot select here specific terpene mix yet. I'm sure they will add that. If you look at other products that they have, for example, CBDA, you can actually pick particular terpene content, which is sort of, I think, quite important. Let me just pick something. It doesn't really matter what. I'll pick CBD. This is their highest concentration tincture, although they have the RSO. But so here you can, for example, pick just pain, or you can also pick particular terpenes. So I think this is probably in the future going to be more or less a standard, because that does, we know, enhance particularities. And mostly what I think currently so far that what I have used CBDV is for different neurologic symptoms and the pain. And so I think it makes sense to add pain component or calming. So they have this calming to mix here, this calm. So I think I covered the dosing and this one of the sources. I will put, I think I already did. I put the link to the CBDV in the chat. But again, it's as you saw on the screen, the company called Miriam's Premium Hemp Products. I'm sure there's going to be other companies that are really good that's going to start adding. I don't know if Dustin Sulak's company started creating this, but I've heard that he will soon add CBDV line to his products. So I expect that the very trusted brand's going to start putting it out there on the relatively upcoming platform.
Yeah, and I heard just the other day that there are some of the bigger brands internationally that have a lot of data and preclinical studies on minor cannabinoids like CBDV. So what's a minor cannabinoid? CBDV, THCV. The issue is essentially, like all things, funding. So there is data out there, and preclinical is animal studies or test tube studies. It just hasn't been aggregated or spread out to the public yet. So we might learn a lot more sooner rather than later. But for now, this is what we have. And then if we have more time, can I talk about my theory that I have that we talked about? And yeah, okay. So something that I've noticed, and again, this is just over one of the unique things that folks like me and Dr. Kogan do. I joke that there's about 25 of us, I think, globally that follow patients long-term on cannabis. Is we start to see things that other folks haven't seen yet in the field, because most people do coaching, but they don't really follow people for months to years, but we do. One thing I've noticed about cannabis as a whole, but particularly about the THCVs and the CBDVs, is the V molecules seem to really affect people with any disease process or chronic illness related to a dopamine dysfunction. So ADHD, neurodivergency, the autism spectrum, Parkinson's, restless leg syndrome.
Well, and even Alzheimer's. In Alzheimer's, especially in the late Alzheimer's, the dopamine definitely is majorly impacted. Yeah, absolutely.
Yeah, so I wonder if there's definitely more of a there, because currently, and tell me if my pharmacology is incorrect here, because everybody else on this panel has learned this much deeper than I have. But when people have dopamine deficiencies, neurologically as a neurotransmitter, sure, we can give dopamine as a medicine, and we do for heart things, but for brain things, we can't just like inject a lot of dopamine because it would make your heart explode. It would be bad. So we have to do things that force the neurotransmitters to like release more dopamine. Like carbidopa, levodopa does that in a pretty fancy, hard to explain way. And I wonder if cannabis, particularly the V classes, have a similar function. That's my hypothesis.
I totally agree with you. I mean, the thinking is that THC can do a lot of that. Like, so the THC is a very potent, inducer of a release of dopamine. But the problem is, again, you probably don't want to release it in a large amount suddenly, which is, I think, what THC does more. And so you want to level things. You want to, especially with the chronic neurodegenerative conditions or autism, right? You want to keep things steady. You don't want to bump them up and down and yo-yo. And unfortunately, that's one of the biggest problems with the Parkinson management. Like the pills, the meds, anybody who has Parkinson know this really well, that they'll take the cinnamon, they'll feel good for a while, and then it'll dissipate, and then they'll feel horrible. So they'll have this peaks and valleys nonstop throughout the day. And so the V's, and probably my guess, Rebecca, is that it's really a symphony of different mixes in the smaller amounts. Because one of the concerns is you can titrate the dosing here a lot, but it's going to be a fortune to cost, because this product's unfortunately not cheap. If they're researching 600 milligrams a day, oh my goodness, that'll be a full budget right there. It'll be thousands of dollars a month. But I'm guessing that when we do full spectrum and when we combine different things, that the dosing is going to be dramatically lower. We're probably talking 10 times lower. That's my guess.
Yeah.
Again, it's all guesses in many ways, educational guesses, but educated guesses. But I think that's what we've so far observed with other conditions. I think we can safely extrapolate the use of this newer cannabinoid too. Thank you for this wonderful, the V aspect. So what do you think, the THCV? Is this something? I have not used that at all. I have no idea.
Yeah. So it was marketed a lot as, we do have it here in Illinois, California has it, Michigan has it. Massachusetts seems to have a lot of it. Colorado, hit or miss sometimes. So the V's, they were marketed incorrectly as weight loss and a stimulant, which is kind of not exactly true. What it does seem to do is it does seem to be more energy inducing. Like, it doesn't seem to have that sleepiness as a side effect that the other cannabinoids do. So that makes me wonder, because like how do we treat ADHD? With stimulants, right? With caffeine. So I wonder if that THCV, people with ADHD report that THCV with a microdose of THC helps with, when they take it in conjunction with Adderall, it helps with time dilation. It helps with stimulation, but without making your heart pound like it's going to jump out of your chest. Because if you take a stimulant plus caffeine plus THC, you can have some really, for lack of a better word, like gnarly cardiac effects. Like, you can have really bad tachycardia. I've seen it as high as up like 160, which is pretty fast. That's for standard trip. Yeah. If it doesn't come down, like, you could really mess yourself up with THC, like too much THC plus coffee plus a stimulant like Adderall, you could feel bad. And sometimes it goes away, and then other times you've clicked yourself into a rhythm you don't want to be in, if you're predisposed to that. So what THCV in smaller increments does is it helps people take smaller THC doses. Seems to actually have, so how we talked, sorry, I'm getting pretty long-winded here, but how we talked about the how things are affected on the cytochrome P450 system is sometimes you could use cannabis and cannabinoids to do other things, because remember, it's stopping the metabolization of other pharmaceuticals if you're using at a specific time and route. So sometimes tricks I've seen people use, and that we've kind of picked up on, is with Adderall, for example, it's digested by bile salts in your gut, not the cytochrome P450 system, very little. Is it actually can make your medicine work a little more, work a little better, have a little bit more going through your system. So if you're not overstimulating yourself with like caffeine, which there's a whole other interaction there, you know, you can make your medicine work better, plus get these added effects of THCV and THC. So that's my long-winded explanation. So help, but without the rip-roaring tachycardia and discomfort.
Yeah, what I'm hearing in terms of the neurodegenerative Alzheimer's and Parkinson, I'm definitely seeing some neurostimulating effect, whether it's uplifting or I wouldn't say better cognition, because we don't have enough data for that, but it's definitely does something in terms of upregulating the speed of processing and concentration and those things. It's just not really clear exactly what and how it works, but I definitely do. I'm guessing it's all going to come down to the GABA and glutamate balance, because those are the areas where if you correctly suppress GABAergic and glutamatic pathways, you're probably going to rebalance some of this neuroexcitation that's toxic, because a lot of people are overstimulated, including the patients who seemingly depressed, but they actually could be overstimulated. If you balance that out, you're probably going to see some benefit. So it's an interesting direction. I hope that we're going to start seeing more animal models for this, because I have not seen a lot of work on this done, and I think it's probably technically challenging. I'm guessing it's not an easy pathway to measure. There's only one study that Abe discussed when they give 600 milligrams and then they assess the GABA, but that's like one dose in healthy people. We would really want to see what happens in people with particular conditions. Are we seeing the same impact, and what does it look like? So that's really good.
Yeah.
Thank you so
And
much.
sorry, I was going to say, and I bet in older adults, the dosing might be higher because older adults actually have less, transmitters, or they don't work as efficiently. So I wonder if the dosing would be higher than your 100.
I think it's always, how it's just like with everything else, it's a titration, right?
Yeah.
We always start a bit low and we try to titrate up, and we'll see what the impact is at some point, right? I mean, you kind of titrate to the first significant benefit and kind of keep it there. There's a couple of really good comments in the chat. Thanks everybody who puts them in. Combining THC with energy drinks, no good. I absolutely
don't do it.
That same goes to combining THC with any other stimulants or any other neurosuppressants, even alcohol. Be careful, because you may end up in a funny territory. And definitely not something you want to experience, especially if you haven't done that. If you're gonna decide to do something like this, please be slow and very, very deliberate, because usually these things happen when you inadvertently take a bit too much than your system is used to. Doubt something horrible can happen, but you don't want to experiment with this for sure.
Yeah. We always teach people to pick a lane. Like if you are a medical cannabis patient and you're like, you know what, I'm going to take a little extra of something because I'm going out. Like if you're going to a barbecue or a wedding, like it is not the time to also have 3 cocktails, because you will throw up undoubtedly.
And then you may also feel other problems for a while.
Yeah.
So yeah, absolutely. Okay, so I don't see any more questions in the chat. Anybody, if you still have them, please put them in. And by the way, I did try to answer the question about the dosing. The way I start is about 25 milligrams once or twice a day, and then titrate it up. Kind of a little bit less than probably with CBD, or somewhere close to that. I think most people end up somewhere between 50 to 100 milligrams a day of CBDV. Again, it's probably going to be continuously changing as we get more experience. So don't think that this is a final say in anything, but we'll see how that plays out forward. I'm thinking, okay, so research on CBGV. All right, well, you guys asking hard questions.
Yeah.
We could take that on for one of the future topics. I don't know anything about it. We'll need to research. It's definitely not commercially available that I've seen, right? CBGV,
Right.
I've not seen that. CBGA, yes, but not CBGV. So how soon should we notice results? Okay, so I think the result, just like with any other cannabinoids that are not THC, you have to hang on to your head for a little bit. They're not going to show up instantly. It's the THC impact that can be very quick, even with the first dose. Anything that's CB, that's CBDV, CBD, CBDA, everything, it takes a little bit longer. Sometimes CBDA I find work fast for like arthritic pain. But other things, not really. You have to be a little persistent. Couple of weeks, I would say. Is that right?
Yeah. And that's once we find a correct dose. So I've seen people, it's a really interesting effect. I've seen people have long-term changes. We've seen changes as late, we've seen changes right away, like 4 weeks, 5 weeks. And then I've seen people have really reduced symptoms 9 months to a year later. Some people go months without getting any effect at all. Like, let's take neuropathic pain, no change for like 6 months. And then one day they wake up and it goes from like 10 out of 10 to like 2 out of 10. It's very interesting. So could be a while. So keep going and work with a coach or a cannabis clinician to help you titrate.
the same. I always tell people at least 4 to 6 weeks, and I explain that, you know, just like antidepressants are working on serotonin and dopamine receptors, these changes take time, and so we're working on along similar lines, and so we should expect a similar time frame, and that's generally when I see people start to see improvements around 4 to 6 weeks. Also, I like to titrate up slower.
I think the point why that's happening and an important compared to THC, because everybody's like, well, I take one hit and my nose goes away. It's a very different receptors and very different mechanism of action. So when you hit the CB1 receptor, you have a very quick, with the CBD, CBDV, all these other molecules, we're not really seeing much of CB1 impact. So we're seeing other things, and those tend to be way, way slower. So weeks for sure, and maybe even months. So that neither that goes to your question for seizures. Yes, you at least weeks, but I wouldn't even stop there. I'd probably keep going for probably upwards of 3 months, if not longer, as Rebecca pointed out, to say, okay, I'm done with trying, it doesn't work. I tell everybody, commit to a good number of months, otherwise you're potentially going to miss the benefit. And then there's another really good question there for chronic pain and inflammation, CBDV or full spectrum. Okay, let's just clarify this again, because it comes up all the time, right? It's a full spectrum CBDV, right? We're not saying that you're just taking CBDV. You're taking CBDV that had everything else in there. Yes, the main molecule is the CBDV in that particular bottle, like this particular bottle. But it's a full spectrum there, plus the terpenes and flavonoids and everything, because we don't want to take that out, because that's seemingly when you lose a lot of efficacy. How plant figured it out, you know, that's an existential question. I think you have a wrong crowd. I mean, maybe we bring a chaplain, one of them. Maybe that's just not a bad idea. Bring someone from spiritual world to try to answer the question, why is the plant cannabis figured this out? You know, I don't think it's a biologic answer, right? I think it's a much more existential questioning, but it seems like that stands. No matter what product you're using, the full spectrum generally appears to be better. Now, of course, the pharma is going to try to develop products that they can patent. That's different from what we're talking about here, because we're not in that particular business. I'm personally not demeaning that business, but I think that's going to take a lot more effort, and price is going to be insane there, and insurance coverage will take decades. So we don't want to wait for that. We have patients who we need to treat, and we know that stuff works, you know, and it definitely full spectrum is more effective than isolates, which is what the term would be. So thank you, Zibunisa, for particularly highlighting that. That's a very important point. So I think we're about 5 minutes out. I want to keep us on time. This is an important question. And Rebecca, maybe you can also help out with this one. So I would say neither no, I would probably keep titrating the dose to some particular pre-designed endpoint, like let's say with a CBDV, I probably titrate it to 100 milligrams a day and then keep it for a while. So I'm not necessarily going to start 25 and wait for 4 weeks to see what happens. That would be probably too slow.
Yeah, we tell people when you titrate up your class of CBDs or your CBGs, because it's a very different effect, we tell people that you can do it's always very wordy and hard to explain. You have to go slower with how often you titrate, but you can do bigger jumps. So if you start at 10 milligrams, hold there for somewhere between 2 to 4 weeks. If you don't notice any side effects or relief from symptoms, then you could go up to say 30, 40, 50. And then you wait 2 to 4 weeks. Same process, you know, do you have side effects? No. Do you feel any relief? No. Then you can do another big jump up to 100. So we have people do bigger jumps, just slower. With THC, we have people do smaller increments faster over.
Interesting. We're doing smaller increments faster with everything, I think.
Yeah.
You know, I wonder.
We have more room for the other ones because we know there's just less side effects unless we see something that tells us that we're wrong. So far so good. So we've never seen any.
Yeah, the only thing I've seen being problematic is with a jumping CBG too fast. Of course, jumping THC happens all the time because people go to dispensary and they get all kinds of crazy advices, but we can't control that much. But we warn everybody. But I
Yeah.
have not seen a lot of issues with CBD. All right.
Yeah.
Yeah. Well,
My titration generally starts at 10 milligrams twice a day for CBD. I like to start, kind of like at a moderate starting point, and then, but I titrate weekly, so 10 twice a day, 15 twice a day, 20 twice a day, 25 twice a day. So by the end of the 4 weeks, you're at 25 twice a day, or 50 milligrams a day, and then we check in, we see where you're at, and then we can continue from there.
and something that I should say, because I just made up numbers to do an example of how we titrate, but something that affects at what dose we titrate and how often, it literally depends on what's the route of administration we're using, what's the route of administration the patient's comfortable with, and how old are they, what's going on, and most importantly, what other medications are they taking and when? Because what we use and how much and how fast or slow we titrate something really depends on the other polypharmacy, particularly with older adults, because we're not just watching for our side effects, we're watching to see if it bumps into anything else in that CYP system.
I think that's the key. I think generalizing this approach, I think everybody does this the way it works for them. But it's so many variables. And I would say that the age and other medications on board are the biggest contributors to this unpredictable responses, which could end up being problematic. Those are the biggest things. And then also just, there's some people who are super sensitive. So those you may need to start a lot lower. And I think we always screen for that. We ask everybody, how sensitive are you? Like if I give you this, what's your prior experience with taking other things? And that's usually a big one. Okay, well, let's do the raffle. So there is how many people we have? We have 10 folks here, right? So the way I'm going to do this is we have 2 products to raffle. We'll start with the CBDA. It's a 750 milligrams of CBDA, so it's 25 milligram per ml. Wonderful product. I personally love take it myself periodically when I'm sore, especially after a long day of skiing or walking. Works really good for me, and I take about 25 to 50 milligrams depending on how sore I am. So I'm going to do this. So it's a random number generated. Let's see. And since we have 10 people, let's generate something here. All right, so I got 2. So let's look at this screen. So that is Lisa Parker. You have just won CBDA. Congratulations. And then we'll do one more. Obviously now it's 1 to 9 since you can't win 2 bottles. That would be fun, right? So let's do that. So, all right, 8. So that would be a person before last. Vicky Taylor, congratulations on winning the bottle of CBDV. So you guys, those of you who just won something, please make sure I have your mailing address to mail them to you. And this is a courtesy of Miriam Hemp Products. If you want to say thank you to them, by all means, please email me and I'll forward you a thank to the company. And we're right on time. And that's quite impressive with us. So thank you, everybody. Maybe let's take 60 seconds. What's next? So who wants to see what next time? So I got that CBGV is one. My concern with that one, if we have no actual practical access to it, I think that conversation may be like a little too academic. I'm not exactly sure that we would want to do that just yet, but definitely we'll put that on our list for next topics. But anything else anybody wants to talk about in the cannabinoids, cannabis, hemp, CBD, any topic, throw in your ideas. And of course, we also, 3 of us, can put our heads together for, I guess the next one will be sometime in the summer or maybe late summer, whenever we get to come up with a new topic. Otherwise, everybody have a wonderful weekend, and thank you for coming.
Thank you, everyone.
Bye.